Ladies and gentlemen, we will call to order our House Insurance Subcommittee for Tuesday, March 30th, 2021. Shelley, if you could please call the roll on the microphone.
Representative Subcommittee. Here. Representative Hicks. Representative Kumar.
Here.
Representative Lafferty.
Here.
Representative Mitchell.
Here.
Representative Rutter. Here. Representative Smith. Here. Representative Terry. Representative Thompson.
Here.
Chairman Hawk.
I am here.
You have a quorum.
Thank you. The chairman detects a quorum. Thank you very much. Ladies and gentlemen, we do have a calendar before us that we will work our way through. If I could make a few announcements as we get started on today's calendar. We do have some requests from some bill sponsors that we will be honoring, and we may have a few things that occur as the meeting goes on today as well. Item number 8 on our calendars, House Bill 451 by Representative Hodges. That bill has been, the representative has requested that that be sent to our last calendar, and I'll make an announcement about that in a moment as well. Item number 13 on our calendars, House Bill number 2, request by Representative Smith has been to roll that bill 1 week. We will honor the representative's request that to roll 1 week. I will make an announcement in this committee, and I will make an announcement on the floor in consultation with Chairman Kumar and Vice Chair Rutter. We have decided that we will announce our last calendar for insurance sub will be April 13th. So April 13th will be our last calendar. Hopefully that will be the last meeting as well. I think we've got a few bills that have not been put on notice yet, and we're working our way through. Hopefully we can get most everything disposed of next week, but our last calendar will be April 13th once again. The roll on item number 8 without objection, and the roll on item number 13, House Bill 2, is without objection. And last calendar, 3 times in a circular formation there. So thank you all very much. We do have a calendar before us right now. Item number 1, House Bill 556. Speaker Johnson, if you're in the room, you're recognized. We have a motion and a second. You're recognized on the bill.
Thank you, Mr. Chairman.
I believe you do have an amendment.
Bill does have an amendment.
We do. Tracking code on Amendment 5906.
That is correct.
We have a motion and a second. Let's go ahead and put the amendment on the bill. All those in favor of putting House Bill 5906, amendment number tracking code 5906 on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. The amendment is on the bill. Please feel free to explain your legislation as amended.
Thank you, Mr. Chairman. The amendment makes the bill. As amended, House Bill 556 is the annual nursing home bed assessment, and this bill renews the annual bed assessment through June the 20th of 2022. And this typically funds 1/3 of the nursing home Medicaid budget.
Thank you for that explanation, Deputy Speaker Johnson. Any questions or comments on the legislation? Seeing none, question has been called. All those in favor of sending House Bill 556 to full insurance committee, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman, committee.
Thank you. We're now on item number 2 on our calendars. We have a motion. We have House Bill 1398 is before us now. We do have a motion and a second on the legislation. Believe we do have an amendment as well. Chair Lady Helton. We have a motion on the amendment. Chair Lady Helton, is that tracking code 5618?
Yes, it is.
All right. Amendment before us, ladies and gentlemen. We have a motion and a second. Tracking code 5618 to go on House Bill 1398. All those in favor of placing this amendment on the bill, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it. We are working on your bill as amended. Chair Lady Helton, you're recognized.
Thank you, Mr. Chairman and committee. The amendment changes, number one, it prohibits PBMs from interfering with patients' right to choose the pharmacy or provider. Number two, it bases the calculation for the coinsurance or deductible on prescription drug or device on the allowed amount of the drug or device. Number three, it establishes that coinsurance or deductible does not mean or include copayments. Number four states that pharmacies cannot be paid below their acquisition cost. Number five changes the effective date for sections 1 through 4, effective July 1st, 2021, and section 5 is January 1st, 2022. In Tennessee, we believe patients should have choice in their health care. Whether it be choosing your doctor, choosing your pharmacy, or choosing the right treatment plan for you, patients should be empowered to make the right decisions for their needs. For too long, pharmacy benefit managers have imposed restrictions on patients' access to care they need by steering them away from the providers and pharmacies they trust toward bureaucratic corporations who seek to increase their profits. Mr. Chairman and committee members, this bill aims to bring integrity back to the healthcare system by addressing the lack of transparency in PBMs and restoring choice back to the consumer. This is kind of lengthy, so please be patient. Section 1 addresses 340B discrimination. 340B entities are safety net providers that serve the state's most vulnerable populations. PBMs can amend a 340B entity's contract and reimburse at a lower rate than negotiated, essentially withholding money from indigent care facilities. This section of the bill will prohibit PBMs from discriminating against these entities so that the nearly 700 340B providers in the state can continue to provide services to the community without financial constraints. Section 2 of the bill addresses specialty pharmacy discrimination and patient steering. Many PBMs own or are owned by the pharmacies they require consumers to use. These PBMs steer patients to their preferred network of affiliated hospitals, providers, and pharmacies in order to maximize their profits. PBMs can mandate that you obtain your specialty infusion or other pharmaceutical drugs from their preferred specialty networks or PBM-owned pharmacies, even if the patient experiences adverse care through drug waste, incorrect dosage, or delays in medication. This section of the bill puts choice back into the hands of the patients, specifically those that are suffering with chronic, complex, or rare diseases. Section 3 of the bill addresses spread pricing and rebate retention. Spread pricing occurs when a PBM charges a health plan more for a certain drug than it reimburses the pharmacy dispensing the drug, artificially inflating the cost. This practice results in higher costs to the consumer while allowing PBMs to divert fees for profit. It is most common with cheaper generic drugs. PBMs receive rebates by offering different types of placement on health plan formularies. The rebate passes through the PBM to get to the plan, and the PBM retains a portion of the rebate as part of its contract. This section of the bill ensures the price reduction negotiated by the PBM passes through the pharmacy directly to the consumer, and that pharmacies are no longer paid below their acquisition cost. Section 4 and Section 5 address transparency. This provision states that a PBM has a responsibility to report any entitlement benefit to both the plan and covered person that either are entitled to. This section of the bill will remove the opaqueness within the PBM system by freeing up data to provide accurate information to patients at the point of care, empowering discussions and decisions about medicines a patient can afford and what it is going to cost. House Bill 1398 will put patients back into the center of healthcare where they belong and give them more access, choice, and transparency.
Thank you, Chair Lady Helton. We do have a couple of folks who would like to speak on this legislation.
Yes, we do.
Any questions of the Chair Lady at the moment? Okay. I think we'll go into recess at this moment without objection. Our friends at TennCare would like to discuss this legislation as well. We have a couple of individuals later on, Dr. Stephen Schleicher and Kim Deal Boyd would like to speak. But at this moment, since we're in recess, we will go to our friends from TennCare and allow testimony. Ms. Reed, you know the protocol. If you could tell us who you are and who you're with, and we'd like to limit you to 3 minutes if we could, and then open it up for questions and answers afterwards.
Thank you, Mr. Chairman,
You're
members.
recognized.
So TennCare's concern with this bill is really around Section 5. The bill language requires TennCare or its PBA to report real-time cost, benefit, and coverage data in a format made by the requesting party of data to the enrollee's healthcare provider, or enrollee's authorized representative. There are no restrictions on the number of times data can be requested upon granting authorization, and there are no restrictions on a third party's use of data beyond the authorized representative. Near real-time data output on this scale is currently unavailable and out of scope for TennCare or its PBA system offerings. We also need to ensure that we follow HIPAA guidelines. TennCare's 3 MCOs would also have to implement and maintain a data system to share pharmacy-related data for physician-administered and inpatient medications, which would have a fiscal impact. Each MCO would have similar startup and ongoing expenses as the PBA. Happy to answer any questions.
Thank you. Any questions or comments for our representative from TennCare while we're out? Seeing none, thank you. And as we do work on fiscal notes, this is something that is important to have those conversations. So as we go forward, we'll certainly work with you on that. So thank you so much. We are now going to go to have 2 folks, Kim Deal Boyd and Dr. Stephen Schleicher. And I think the testimony is going to be separate, but feel free to join us at the tables once we get disinfected there. Ms. Boyd, we will recognize you first. If you could please introduce yourself, tell us who you are and who you're with, and begin your testimony. We have, again, 3 minutes, and then we'll open up for questions and comments afterwards.
Thank you, Mr. Chairman and committee. My name is Kim Boyd, and I am a resident Tennessean. I was born and raised here. I grew up in Mount Juliet, and I live in Rutherford County. But I'm also head of public policy and industry relations for an entity called Cover My Meds, which is a health innovation technology company that was founded in 2008. But prior to getting into public policy, I was also in operations. I was in operations for a medical services and pharmacy benefit management company. So that gives me unique insight into what we're talking about today with House Bill 1398. I'm here today in support of this bill, which is the Patient Access, Choice, and Transparency Bill. More specifically, I will talk to Section 5, which was just referenced by my colleague in healthcare from TennCare. It is inherent upon us to embrace the call to action in this legislation and to create change not only for ourselves and our families, but for all Tennesseans. A prospective, comprehensive view of our patient-specific eligibility, benefit, policies, and terms is lacking in healthcare today. For far too long, there has been significant opaqueness in healthcare that harms patients and actually is a fiscal stain on the healthcare system itself. Billions of dollars a year are wasted on archaic and highly burdensome administrative tasks that can and should be automated. Patients routinely abandon their medication treatment due to unknowns, and the lack of real-time information being provided at the point of care is problematic. I'm sure that you and or a member of your family have experienced these unknowns. Am I covered for the treatment or the medication that my provider is ordering? If I'm not covered, can I still obtain that treatment? Or what other options do I have? Why didn't I know that a prior authorization was required for said treatment? How far along am I in meeting my deductible as a patient or as a family? How much will it cost me? The data and the said sharing of the data called out in Section 5 in the PACT Act is not new data. It is not new data that needs to be aggregated. It is not new data that is being shared. It is already being shared in healthcare, just not prospectively. Planned data sharing with PBMs and the aggregation of yours and my patient health benefit information has been going on for decades. In 1968, the first PBM was founded when pharmaceutical card system invented the plastic benefit card. By the 1970s, PBM served as fiscal intermediaries by adjudicating prescription drug claims by paper, and then in the 1980s started electronically. In 1988, the first electronic claim was transmitted and data was exchanged with pharmacies, giving them insight in real time to what our patient-specific benefit and cost and eligibility information is. PBMs connect today electronically with switches, intermediaries, and entities in the industry to adjudicate claims and to share with pharmacists today that data we're talking about. The PACT Act would securely move your patient information upward and upstream to be shared in real time with you as a patient and or your provider. It is consented information already being shared today. We're just asking for it to be moved upstream. Without this comprehensive view of our eligibility and benefit data, we are hindered as patients to understand fully what our options are, and we will continue to be surprised as patients when we get bills in the mail. Providers will continue to be confused about what they must do to ensure their patient can access the treatment or medication they need, and will continue to be burdened by the excessive and costly administrative tasks that they encounter on a daily basis. Real-time data sharing and transparency leads to better care coordination. Fewer delays in access to care can lead to better outcomes, better experiences, and lower healthcare costs for Tennesseans.
Thank you, Ms. Boyd. 3 minutes goes quickly. So
Yes, sir, it does. Thank you so much, Mr. Chairman.
thank you so much for your comments. I appreciate that. Any questions or comments? Yes, Chair Lady Smith, you're recognized, and then Representative Lafferty.
Ms. Boyd, thank you for your testimony. Just as a clarification, so what I'm hearing you say is the data that you're wanting to be made available through Chairman Helton's bill just empowers patients to know more information about their own medical decisions, their own medication, and potentially their costs. So price transparency is more a part of information as opposed to necessarily giving them the power to steer direction, but you're just saying that this is information that now would be available to the patient and not just hidden within a contract. Is that correct?
That is correct, Chairman.
Thank you.
Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman, and appreciate your testimony today. I want to back up and touch on, you mentioned you were in the field, worked with or for a PBM for a little while.
Yes, sir.
Most businesses that most of us are familiar with have got manufacturer, wholesaler, distributor. The more I learn about this, it seems to me that these PBMs, however innocently they started with a card for drug care, have somehow worked their way into that distribution cycle. They are owners of pharmacies. They are directors of, I guess, what kind of drugs get made. They steer folks back and forth. Could you elaborate and just try and fill in some of the blanks, some of the gaps, and how this works and how they came to fit in this role?
Well, you're correct. So the pharmacy benefit management industry, really started out in the 80s, and they really took off, with the electronic exchange of information and being able to help insurers, self-funded employers manage what was a growing and burgeoning part of healthcare, which was the pharmacy benefit management side. And they had expertise in helping insurers and employers figure out what are the best options to get their patient on the medications that they need, evaluating the drug cost and drug spend in the industry, and creating benefit design specifically designed around those therapies that were clinically appropriate and or costly. As we've grown in the industry, the trend has really been focused more on the high cost of medications that are coming out of market. But you're correct. We started with individual entities that were separate and apart from the totality of healthcare, being advisors to the industry. Now you have, to your point, sir, entities that are now integrated into health systems, owned and operated by health plans owned and operated by different entities owned specialty pharmacies. Where they did not used to own specialty pharmacies, they started acquiring this. So we've moved away from an fully advisor role as PBMs into an integrated part of the money-making machine.
Thank you for that clarity. I don't have any other question at this time.
Thank you. Dr. Schleicher, you are recognized. If you could tell us who you are, who you're with, in 3 minutes, please, and then we'll go for questions, comments.
Hello. So, Chairman and members of the committee, thank you very much for allowing me to be here today and time to present about this bill. I am going to add one thing that was brought up last year in 2019 across the U.S. $125 billion.
Did you give your name?
I'm sorry, Dr. Steven Schleicher, medical oncologist here, practicing primarily in Lebanon, Tennessee, Nashville native as well. Thank you, Chairman Hawk. Just want to add briefly, last year, or in 2019, $125 billion were spent on rebates in the United States. For every dollar on rebates that doesn't go to the patient, the price of the drug goes up $1.17. This is a big problem. Today, I want to talk about 3 patients through my group that have been negatively impacted by patient lack of right to choice. Tennessee Oncology has 34 clinics in rural areas across Tennessee. I myself am an oncologist, and a lot of my patients have incurable cancer that causes pain, anxiety, financial toxicity, and many other things. And while that patient's trying to stay strong for him or herself and their family, we have an excellent cancer team to help them. This includes myself, my nurse, a palliative care provider, nutritionist, and a pharmacist. As drugs go from IV to oral, that specialty pharmacist is more important than ever. If a patient has high copay, we find assistance. Tennessee Oncology spent $48 million out of our pocket to provide free drug on the oral side for patients. If a patient has distress, I know about it. If they have diarrhea, the pharmacist can link me a message. If the patient's stressed and missed a dose, I know about it. If they didn't pick up the drug, I know about it. This is what's supposed to happen. 35% of the time, PBMs and insurers have forced our patients to use other pharmacies. I want to go through 3 examples of this and how that is different than what I just described. The first is a 63-year-old patient of myself. He has 3 kids. He's 60. He has pancreatic cancer. In this case, we're actually going for cure. As part of that cure, he's got to get to surgery. And to do that, we are using radiation with a chemotherapy pill that must be taken on the day of radiation. In his case, the drug had to be shipped through a Credo, which is not us, through the PBM. And we found out about halfway through that he was running out of his pills the next day. We contacted his specialty pharmacy. I got my pharmacy involved as well. He came back 4 days later and had not received his oral chemotherapy pill yet. Frantically in clinic, we tried again, and finally, the drug had to be shipped through our own pharmacy at a price actually cheaper than what his insurance had demanded through their specialty pharmacy. Another case, a patient who has metastatic kidney cancer, again, not curable, on 2 oral drugs together. The goal of this treatment is to improve quality of care and reduce symptoms from his cancer. For a year, we had prescribed those drugs through our pharmacy using copay assistance. His insurance switched, and thus he was forced to pick up his drugs from a different specialty pharmacy. One of those specialty pharmacies did not have access to copay cards, so his price went up and he didn't take his medication. The other drug, the specialty pharmacy did not even carry. They didn't have that drug. He went 2 weeks without the drug before we finally got the insurance to override it so we could supply the drugs ourselves, and also taught the specialty pharmacy how to get the copay assistance for his other drug. A third final case, a patient with metastatic colon cancer on an oral drug, which is 3rd-line treatment. He started treatment with one of my colleagues and had the first cycle, came back 6 weeks later for assessment on the 3rd cycle, and we found out he had not received his drug for the time in between and missed a full cycle because we had no control over that process and were not communicated as well. This is not how it should be for these patients. We're not asking to demand a patient to go anywhere. We just want the patient to choose where he or she picks up their important anti-cancer drugs. Thank you.
Thank you very much, Dr. Slacker. I appreciate your work as well. Thank you so much. Chairlady Smith, you're recognized.
Dr. Slacker, thank you for being here. I'm going to ask you, because you're in clinical practice, if these are true statements. Is it true that the major third-party administrators, the major plans, whether it be Cigna, Aetna, United Healthcare, Humana, do each of these own their own pharmacy benefit manager companies?
Yes, and specialty pharmacies.
So each of the companies that I just named, again, they're great partners. We need them. So Cigna, Aetna, United Healthcare, and Humana all own their own pharmacy benefit manager and their own specialty pharmacy for which they steer their own patients toward, and they determine within that vertical alignment, they determine the formularies, the things that are not covered, and they steer patient care.
Yes.
Mr. Chairman, one more. And what is the implication to you as a practitioner in making these decisions? Or do you have let's say that you've got a pancreatic cancer patient, and you want the standard of care, which is published in the journals, but let's say that is or is not covered. How do you navigate those channels? And if you could make that, there's a very robust discussion about things like medical necessity in this body right now, along with some other things. I'd just like for you to speak as a clinician about how you navigate different healthcare plans.
Yeah.
Thank you.
No, thank you, Chairman Smith. It's challenging, most importantly. Often I have to get on the phone with someone from the insurer who sometimes can't pronounce the name of the drug and explain why it's needed. And the bigger issue is delay. Often a drug that I know is standard of care, that is NCCN, which is our national guidelines recommended, we have to wait weeks to get that drug approved for unnecessarily just to make sure it fits in with the plan. So it takes time away from me, but way more important, causes a lot of headache and anxiety for the patient who's waiting for the drug they need.
Thank you. Any further questions or comments? Dr. Schleicher, Ms. Boyd, thank you very much. We appreciate that. Thank you. We will go back into session. Once again, ladies and gentlemen, we are on House Bill 1398 as amended. Any questions or comments for Chair Lady Helton? Seeing none, are you ready to vote? All those in favor of sending House Bill 1398 to full insurance committee, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it.
Thank you, Mr. Chairman and members.
Thank you. Your bill moves forward. Thank you so much. We're now on item number 3 on our calendar, House Bill 979 by Chairman Williams. Chairman Williams, you are recognized on House Bill 979.
Thank you, Chairman, members. It's great to be back in Insurance Subcommittee. It's been a while.
You say that with such gusto. So
yes, I do.
We do have an amendment, I believe, on your bill. Is that tracking
Yes.
code 5743?
Yes, sir, it is. Happy to discuss the amendment.
Let me jump back and make sure. We're back on House Bill 979. I heard a motion. Do we have a second? We have a second on the bill. Now we're going to go to amendment tracking code 5743. Do we have a motion? We have a motion and a second on the amendment. Ladies and gentlemen, let's go ahead and place the amendment on the bill, and then we will have description by Chairman Williams after that. All those in favor of placing amendment number 1, tracking code 5743 on the bill, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it. We are on your bill as amended for description.
Thank you, Chairman and members. During the pandemic, we found out that sometimes members of our community didn't have all their ducks in a row or weren't able to manage the bumps associated with COVID. Last year, we carried this bill for the very first time. The Senate, as you know, didn't do very much last session, but this bill, this committee passed last year, but what it would do, it would allow for automatic enrollment of people in long-term, short-term disability. It's currently the operating procedure for some companies to do that. And then those citizens would have the opportunity to opt out of that coverage within 30 days if they want to. This does have a small fiscal note, but it has to do with the tax credits. This law would encourage our employers to enroll people early on in order to utilize these tax credits. In so doing, it would protect these citizens. As many of you may know, you may have long-term or short-term disability coverage. It's very inexpensive, and so it's one of those things where we can give businesses an opportunity to support their citizens through this tax credit and auto enrollment. I'm happy to answer any questions the members may have.
Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. I agree with you. Thank you for bringing this. Disability coverage is really important. I was curious that is this covered by the employer, or does the employee pay part of the premiums?
Thank you. It just depends on the employer themselves. In the instance of the company that I work for, I pay the short term, they pay the long term. So it really depends on the employer relationship. But this would allow for auto enrollment of both.
Well, thank you. That would determine sometimes when employees do not sign up, but it's always a critical thing in life.
Yes.
Thank you. Thank
Thank
you,
you.
Mr. Chairman.
Thank you. Any further questions or comments? Chairlady Smith, you're recognized.
I just want to say thank you. One of the things I think we overlook is the fact that for those that do not have disability insurance, I would assume it's fair to say, Chairman, that these people end up on TennCare if they don't have that. So this is a mechanism that will protect our tax dollars. So thank you.
Thank you. Representative Thompson, you're recognized.
Thank you, Mr. Chairman, and thank you, Chairman Williams, for this bill. I worked for a long time in human resources. During part of the duties I had, I managed benefit programs, and I worked for organizations that had the auto enroll and some that did not. And I saw a lot of the difference, especially when you had employees coming back later who were disabled, and the standard of what we could offer them with long-term disability and without it too. So this is a good bill, and it'll be at the benefit of working people all over the state. Thank you.
Thank you. Any further questions or comments? Seeing none, we'll be voting on House Bill 979. The motion will be to send to full insurance committee. All those in favor of House Bill 979, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Chairman and members.
You are recognized. We have item number 4 on our calendar. Chairman Williams, you are also recognized on House Bill 988. We have a motion and a second.
I also have an amendment for this bill, drafting code 005550.
All right. We have a motion and a second on Amendment 55, tracking code 5550. All those in favor of placing the amendment on the bill, please signify by saying aye. Aye. Any of those opposed, please say no. No. The ayes have it. Barely. We are moving forward on House Bill 988 as amended. Chairman Williams, please explain.
Thank you, Chairman and members. House Bill 988 originated last year in a discussion and then followed again this year. House Bill 988, as amended by this drafting code, addresses the lack of oversight of air ambulance companies and their membership plans in Tennessee by redefining the sale of memberships as insurance, as they currently aren't. These memberships are sold to protect against future medical expenses, just like other insurance types of insurance would. Instead of working to go in network with insurance companies, some air ambulance companies offer membership fees to cover out-of-pocket expenses or deductibles. In the same way, insurance protects medical expenses, and gap insurance covers deductibles. This bill does not remove the ability for any of these folks to operate their businesses or to offer memberships. It simply allows Tennessee Department of Commerce and Insurance to ensure that consumer protections are in place to make sure the citizens of Tennessee are protected. These memberships act as a form of secondary insurance by protecting citizens from out-of-pocket medical expenses and deductibles, and should also be subject to the same consumer protections as other insurance products do. Chairman and members, I'm happy to answer any questions that you might have.
Thank you. Any questions or comments for the chairman? Chairman Sapicki, you're recognized.
Thank you, Mr. Chairman. Chairman Williams, we've rode on many horses together on this, and this is one I'm not going to be able to ride with you on. I have firsthand experience with Air Evac when I was living in Missouri, of somebody that had a tractor accident, and they responded in a very quick way. I've had it when I've lived on the farm to provide that level of coverage for myself and my family, that if there ever was an incident, they would respond in a hasty way to get me to where I need to go. It seems to be working rather well in Tennessee. I'm not aware of any complaints that have been brought before myself or any other member that I know of. And this is very important for people that don't have a lot of money, that live in very rural communities in Tennessee and across this country, that have access to medical care within a flight. That could be the difference between life or death. I know there's going to be an argument for this. I get it. But I'm just struggling with trying to regulate something that seems to be working rather well. And I don't want to put them under the bureaucracy of insurance and have to meet all that and then start to drive the cost up to our rural communities of people that really can't afford much more, but just the safety of a flight. So that's all I want to say, Mr. Chairman. You don't have to give a response if you don't want to. That's fine.
Chairman Williams, you're recognized.
Thank you, Chairman Spickey. I appreciate your comments. I think your comments are valid. I do think in this instance, though, as I stated previously, that this does not prohibit anyone from being able to currently do that. There is no imposition whatsoever on the air ambulance folks. In this instance, it allows for consumer protection. And if what you say is correct, and I have no reason to disagree with what you're saying or what they might even say as to whether there's any complaints, if there are none, then there should be no concern. If as it relates to a consumer protection model, I agree with you. We never really want to add additional bureaucracy, but we have bureaucracy in place sometimes in order to protect citizens in this instance. I have the opportunity to buy through my insurance company a discounted rate for these air ambulance companies, and I think they provide a much-needed service to not just the rural Tennessee, but other areas across Tennessee as well. And so I get your points, but this would not give any imposition to them whatsoever, except for reporting to Commerce and Insurance, and that's all. Thank you.
Representative Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman. Kind of along the lines, I guess, of if it's not broken, I'm not sure exactly. I hear the consumer protection side of things, but if the consumers aren't clamoring for it, I'm not sure what we're looking to do beyond that. Also, it seems everything that we're talking about healthcare, right? We're moving this into kind of a healthcare kind of insurance policy. I don't need to tell this room how much out of whack healthcare costs are. I worry that this might have some negative impacts on the cost of the people that are currently using the services because of the involvement with insurance, healthcare, however you want to phrase it.
Thank you. Chairman Williams, you're recognized.
I honestly have no idea how to answer your. I didn't hear a question there at the end. At the beginning, I think in this instance, this is an entity in which 300,000 citizens of Tennessee are paying for these air ambulance memberships. Thankfully, not many of them are needing them, and that's the nature of an insurance policy. In most cases, people can be transported using an ambulance and not an air ambulance, and a lot of that based upon that availability, even if you were in a rural area. And so the costs for Medicaid and Medicare are already covered for air ambulance, and so all this would do would protect those citizens who may have bought a membership somewhere and then someone else ended up picking them up. This would allow us to be better manage how that process works. So.
Thank you. Chairlady Smith, I think you were going to make a request.
Yes, Mr. Chairman, and I would like to hear from the department just to understand what this type of oversight would look like, but I do have a question of the bill sponsor, if you might entertain that.
You're recognized.
Because I'm unfamiliar with how these work. Is there a possibility that a patient could be given a balanced bill in a case of they pay their $65, $85, $105 monthly membership, but they have to engage? Or is there any sort of protection in place should they have to use that all of a sudden there's a bill that exceeds that monthly charge and it's going to be in the tens of thousands of dollars? And the reason I ask that question is that is one of the main issues behind the air ambulance surprise billing issue, is when there is a balance bill, it bankrupts people. But thank you for the question and the opportunity, Chairman.
Thank you. I think while we're still in session, you have Chairman
Well,
Williams.
just to answer a question, sometimes there is an issue as it relates to balance billing. I think the main thing, anytime you have consumer protections, is managing expectations. I know when I attended an air show in the Upper Cumberland, I was given an application to be able to do that. And when I walked away from it personally, I was thinking, well, this might be a really good idea. Maybe if something were to happen to me, I'd be covered. But I really didn't know what it was covering. And so when you really don't know until you get a bill, and then you don't know what the coverage entails or whether the person you bought a premium from actually provided that service. So, or in this case, it's not a premium, it's a membership. But I'm happy to answer any other questions. I know, Chairman, there are some others that like to testify. I'm happy to stand away.
I think Representative Mitchell has a question or comment. You're recognized.
Yeah, thank you, Mr. Chairman. Yeah, I'm just trying to figure out, and I'm kind of on the fence on this because I see this as almost an ancillary insurance product, so I almost get the idea of where you're going. But I also, too many times down here, we seem to get involved in picking winners and losers in an industry, and I'm trying to figure out, is that what we're getting into in this situation? Because there seems to be two competitors. One seems to be a better marketer than the other. One may be slightly above the other one in other areas, and they're just mad because they hired a better marketing person than they did. And I'm just trying to figure out, from your standpoint, if we're not getting the complaints, I'm kind of along with the lines with Representative Lafferty. If it's not broke, don't fix it.
Mm-hmm.
Chairman Williams.
I can't, thank you, Representative Mitchell. I can't speak to the big guy and the little guy or the excellent marketer or whatever, but our role as citizens, legislators, is to protect the citizens, really. In this instance, in looking at the way this process works, I feel like that this would be a good thing. It's not like anyone's saying you can't be in business because you don't have a good marketer. All we're saying is that because they're providing a club, a marketing membership, and there are citizens who are buying this in the numbers of hundreds of thousands of Tennesseans, I believe it's in the state's and the citizens' best interest to have Commerce and Insurance at least oversee it.
Chairman?
You recognize Representative Mitchell.
Yeah, and I kind of agree with you in protecting the public, but unfortunately, I see every day there are so many areas, whether it be in the lending industry or, insurance products out there that I think, in my personal opinion, consumers are wasting their money, and we ought to do something about it. Or gambling in this state, we're allowing it. So, I think this is probably low on the totem pole of of things we ought to be doing. But I appreciate your efforts. Thank you.
Chair Lady Rudder, you're recognized.
This is another one that I guess I can't be with you on this one, and I have told you that. I had quite a bit of interest in this bill, and did some research, and what I found out, and I don't guess I have a question, it's more of a statement, but what I found out that in my county, my district, there was over 4,300 people that have bought these memberships. I also found out that a lot of times in these rural areas, people buy. I had one gentleman told me he bought a 5-year membership knowing that he would probably never use it. But what it did was help get an air ambulance via the memberships into his district. So that was so important in a rural area. The other thing that I would like to add was that I did ask the Department of Health, had there ever been any complaints about air ambulances? And I will tell you that the answer was no. So after all of that, those are the reasons why that I want to tell you that I can't support your bill, and I'm sure you understand that. I live in a rural district. It is important, and I understand the concept behind selling a membership that may not be needed, but this boils down to regulation of an industry that I think in rural areas in particular is a big help. Thank you.
Thank you. Chairlady Smith, did you want to be recognized, I believe?
I did, and I was going to ask if I could just speak to the sponsor and ask if I could work with you possibly on an amendment or put this in a position where I don't think anyone argues on this panel, we need some consumer protections, but I think you hear that we also don't want to interfere with, don't want to pick winners and losers, as it were. So with Mr. Chairman, I'd like to ask you if you would entertain a motion to roll this for 1 week.
That would be fine with me, Chair Lee. I'm at the will of the body. I'm happy to work with anybody on it, and I'm at the will of the body. So I would welcome that if that's what the Chair Lee chooses to do.
Okay, thank you very much. The chair will entertain that. We will roll this bill for 1 week. Seeing no objection. House Bill 988 is rolled for 1 week.
Thank you, Chairman and members.
Ladies and gentlemen, I'm going to hand the gavel to Chairman Kumar. We're going to be taking up a few more bills. I've got to go present a bill in another committee. I'll be back as quickly as I can.
Thank you, Mr. Hawk. We'll move on to item 5 on our calendar. It's House Bill 0677 by Vice Chairman Hall. Do I have a motion and a second? Chairman Hall, you're recognized on House Bill 0677. Is there an amendment?
Yes, sir.
Okay.
Drafting Code 5920, Mr. Chairman.
Okay. I'm told that the amendment was not timely filed, and I'm also told that that your office's ruling is that you're not planning to move on it.
Yes, sir. Mr. Chairman, thank you. This is a step therapy reform bill, and I seek direction from this committee. I certainly don't have enough votes to get it done because it has a physical note, of which I respectfully disagree. Basically, step therapy reform is if you diagnose with a illness or disease, the patient and the physician has a relationship on addressing the most aggressive and the most effective treatment. The way it stands now, you have to go through a series of drugs and treatments before you get to the most effective. This would bypass that, therefore giving cost avoidance, which would eliminate the physical note. And this has already taken place in 26 other states, and I haven't figured out how they're doing it yet, but I haven't give up. So I seek direction from this committee on how we need to move on this.
Well, just as a personal observation, I would say that I wish there was a balance in life in the sense there are situations where step therapy is the right thing. You want to try drug at step number 1 and number 2 and move on. And then there are situations where certainly experience has shown that following those steps is a waste of time, and if the life is in danger with the cancer growing, maybe it's better to move to the ultimate, which generally costs more, and that's why there is resistance to it. And certainly, we don't have a crystal ball, but I think the decision may be left between the research and experience what the effectiveness of step therapy in a particular situation is. But that aside, as far as the bill is concerned, if your feeling is that you do not have the votes to pass it at this time because of the fiscal note or other considerations, then I would think the best course will be to postpone, take it off notice, or roll the bill until you can work with the stakeholders and see if you can have a good lunch or dinner with them, and you guys can convince each other. It's a matter of working with them, and what I found is that personally, it's good to touch base with the person who opposes you first, because you learn from them, and working together, we come up with better legislation that serves our citizens better. Members, do we have any other direction or advice for Chairman Hall? You're recognized.
Thank you, Mr. Chairman. I believe in the bill, and I don't think there's another bill drafted on the Hill this year that affects Tennesseans in a more positive direction. When you have a family member or even yourself that's diagnosed with cancer, you definitely want legislation like this in place. But, Mr. Chairman, if I may roll this to summer study to tie up some loose ends and to dress it up, and I'll bring it back next year and present it in more of a neat package with a bow on it.
Well, thank you and good luck to you. Without objection, House Bill 0677 goes to summer study.
Thank you, Mr.
Thank
Chairman.
you.
Committee.
Item 6 on our calendar is House Bill 1463 by Representative Cochran. We have a motion and a second, and I don't see an amendment. So, Representative Cochran, you're recognized.
Thank you, Mr. Chairman. And admittedly, it reads a lot like caption text. You would think that there would be an amendment, but truthfully, it does exactly what it says. It's simply a bill that clarifies a section of code, and it says that basically an insurance company is allowed, if they want to offer a plan where if you as a patient go to the doctor, negotiate a cash rate, you can get reimbursed for that from your insurance company. Again, there just seemed to be a little bit of confusion in the market whether or not that was allowed. This just clarifies it, and hopefully that clarification will result in some innovation.
Thank you. Appears to be a very simple business model. Members, do we have any questions? Chairman Smith, you recognize.
Thank you for bringing this bill. I'm just curious, is this something that you're seeing or have seen in another state where there are plans, or, because I know here in the state of Tennessee, we have passed the associated health plans. We've done the direct medical contracting where you don't have to have insurance and you engage directly with your provider on a menu of services. And I'm all about innovation that knocks down barriers. Where have you seen this?
Sure. Well, and sort of, Mr. Chairman, if I may,
recognize.
Sort of in response to all those, and honestly though, because obviously typically this is not my policy area of expertise, admittedly, but we looked at this section of code some last session, just looking at the assignment of benefits, how it works in Tennessee, and this was just one of the discussions that came up, just one of the things that currently is not taking place in Tennessee, and just through that discussion, I felt like if we just clarified that, look, the way our code is written does not prevent this, that it, could possibly result in some innovation. So honestly, it was just through discussions on a related subject brought this to my attention.
Chairman Smith?
And I would just like the testimony to be that this is how it used to be. And when costs were a little better.
Yeah,
where
absolutely.
the patient negotiated with the physician, and then we were reimbursed. So I thank you for bringing the bill.
Thank you.
Yeah. Thank you. You're right in the sense that it used to be that when you went to see the doctor, you signed a piece of paper assigning the benefits or not assigning the benefits. If you assigned the benefits, payment went to the physician. If you did not sign, the payment came to you.
Sure.
But anyway, I think you're simplifying the matter and giving people a choice. Any other questions, gentlemen? We have a motion for question. All those in favor of House Bill 1463 going to full committee, please say aye. Aye. Opposed? The bill moves on to full committee. Thank you.
Thank you, Chairman and Committee.
Next is item 7 on our agenda, House Bill 1453. That I'm told is rolled 1 week without objection. Item number 8, House Bill 0451. Okay, so we are in a rolling mood. 0451 has been rolled to the last calendar, and item 90875 is also rolled to the heel of this calendar. That brings us to item 10 by Representative Rudder, House Bill 0619. We have a motion and a second. Don't see an amendment. Vice Chair Rudder, you're recognized on House Bill 0619.
Thank you, Mr. Chairman and committee. House Bill 619 would require insurance companies to apply the value of drug coupons to their enrollees' deductibles. Many patients, especially those with chronic, complex conditions, rely on copay assistance programs to afford their medications. These programs offer vital financial assistance to help cover out-of-pocket prescriptions. They help our people get their medicines. House Bill 619 makes sure that the value of the copay assistance programs counts toward a patient's annual deductible. This is a good bill for our constituents, and I do hope that you will support House Bill 619. Thank you, and I will take any questions.
Thank you, Vice Chair Rudder. Certainly seems to be the right thing to do. Members, do we have any questions? Seeing none, are we ready for the question? Without objection, we are voting on House Bill 619, moving to the full committee. All those in favor, please say aye. Aye. Opposed? The bill moves on to full committee. Thank you.
Thank you, Chairman and committee.
Next is item 11, House Bill 1258 by Chairman Smith.
Thank you, Mr. Chairman and committee. I do
Let's
have
get a motion and a second. Do I have a motion? Do I have a second? We have a motion and a second. And go ahead, you're recognized.
I do have an amendment that makes the bill. Is drafting code 6197, Chairman.
Okay. Yes, we do have 6197. Do I have a motion on the amendment? It's not listed on the marked calendar, but it is on the dashboard. We do have a motion. I'll second it. So we have a motion and second on amendment 6197, is it? Yes. Let's attach it to the bill, and then Chairman can explain us about the amended bill. All those in favor of attaching amendment 6197 to House Bill 1258, please say aye.
Aye.
Opposed? The amendment goes on the bill. Chairman Smith, you're recognized.
Thank you, Mr. Chairman and committee. As part of the federal No Surprise Act that settles the ERISA plan issue of surprise billing, in that language, there was enabling monies that were made available to all states for an all-payers claims database. An all-payers claims database, it will be a clearinghouse of information that the Health Services Development Agency oversees. It will be very much protected. The data will be protected. The purpose of this is to aggregate the cost of services in a blinded fashion so that patients will be able to, that information is provided to the state. They can benchmark and compare costs and provide information. Also, part of the arbitration settlement period in the Surprise Billing Act federally, and even if we have a state level remedy, this will be a tool that's used. The Logan Grant here has been working on this particular amendment for about 2 years.
It is. It's not on this one.
Do you have questions, Mr. Chairman?
Just a little bit of housekeeping. I apologize. It's a long amendment. It's a 13-page amendment, and there are apparently more than one marked calendar. Some marked calendars did carry this, others did not. So honestly, have not had time to look through it.
Well, Mr. Chairman and committee, I'm happy to roll this to the Hill to give the body time, but would be happy to entertain questions now.
Okay. Members, do we have any questions? Let me seek opinion from the committee itself. Representative Lafferty, you're recognized.
Thank you, Chairman. I was told earlier that there may be some identifying information in here where information can be tracked back to individuals. Could you elaborate on that?
Chairman, you're recognized.
Thank you, Mr. Chairman. And the information the state will have, in place already, whether it's TennCare, whether it's the state of Tennessee, there is an agreement that this is proprietary. It will not be used for public consumption. So the information provided to HSDA will not be released to the public, and so it has the same protections that whether it's Blue Cross Blue Shield submitting the data, whether it's Cigna, Aetna, United Care, Healthcare, or Farm Bureau, the same information and the same protections that are in place with those third-party administrators, they will be observed with the state.
Representative Lafferty?
Thank you, Chair. And that information, so it can be, the state would be able to identify who the individuals were that were identified by this process.
Chairman Smith.
If the chairman would honor my request, I'd rather that question be answered by the individual who is in charge of this, if we could go out of session, because again, I'm carrying the bill for HSDA, and I would prefer them to answer the question with all authority rather than me misrepresenting the facts.
Okay. I'm told that the party did not ask to be on the list, and considering our House rules, we do need a notice 24 hours prior. So we are not able to do that. Considering that and the considering question of a 13-page amendment, I think our direction is becoming more clear.
Right.
But may I ask you a very simple question? This is going to be creation of all claims payer database. Would that contain the amount billed and the amounts paid, or which data will that contain?
Thank you, Mr. Chairman. It would include a whole list of information that is laid out by the federal bill. This is this is an enabling piece of legislation. We're not making the determination here in the state of Tennessee. There will be a national platform that is constructed, and every state will have a minimum or a floor of information that will be collected. The monies that are available from the federal government total to be $2.5 million. The HSDA has already begun engaging with various vendors that they would receive $1 million for the first year, $1 million for the second year, $500,000 for the third year, and again, every state will be forming their own all payers claims database, and that will be part of the information that is disclosed to the state, but that will not be the only information. It won't just simply be the amount billed, the amount paid, but it will be other information about the patient care and transaction.
I should have figured that out. The federal government is asking to be created. It will include everything. So back to the direction of this bill, it appears that considering the 13-page amendment, considering the fact that we cannot hear from the agency that's going to run it, we will roll it to the heel of the calendar without objection.
Thank you, Mr. Chairman.
So done. You're welcome, Chairman. Which is the next item is our... Yes. Next item 12 on our... Right. We can do that. We can allow. Pat, kindly have a seat. I need to set the background for you so that our members know what the bill does and why you're testifying on it. Well, I'm not able to do that, Mr. Pate. Can you enlighten us?
Sure,
Kindly
I will try
state
my best.
State your name and who are you with, and then kindly tell us what this is all about.
Thank you, Mr. Chairman, and really appreciate members of the committee for allowing me to speak this way. My name is Randy Pate. I'm the founder of Randolph Pate Advisors. It's a strategic marketing and consulting firm, but for purposes of this discussion today, I'm the former director of CISIO. It's the Center for Consumer Information and Insurance Oversight. It was within Centers for Medicare and Medicaid Services, and I served in that capacity for 4 years, and we had oversight over the individual health insurance exchanges. We ran healthcare.gov and then also oversaw the state-based exchanges. And so really the discussion today that I wanted to talk about with you all is the issue of Tennessee building and establishing its own state-based health insurance exchange. And so I want to talk about this because I think it's a really important discussion in terms of Tennessee taking back control over its health insurance market. So in my role, as I stated before, at CISIO within CMS, we ran healthcare.gov, and we also worked with the state-based exchanges. There are 29 states that are currently still on the healthcare.gov federal platform. But based on this experience, I can tell you really firsthand of the importance of states in regulating their own health insurance markets. States, rather than the federal government, are in the best position to address issues unique to their markets and to their citizens. States are more responsive to the specific needs of their communities and are better able to protect the interests of consumers. And states are at the forefront of creativity and innovation in addressing the crisis facing America's healthcare system. I'm going to argue in just a few minutes here that establishing a state-based exchange is a very important step for Tennessee to break away from the federal government platform and to chart its own course in healthcare in a way that's market-oriented, fiscally responsible, and responsive to the needs and preferences of Tennesseans rather than the desires of politicians in Washington, D.C. I want to make clear from the outset, and I would like my testimony to reflect that this discussion is not at all about Medicaid expansion and really has nothing to do with that. It's really talking about private health insurance and the individual insurance market. Under federal law, a public health insurance exchange serves as a gateway to access federal premium tax credits. Exchanges also play an important role in how consumers shop for and enroll in coverage, provide not only the front-end shopping experience through the exchange website and application process, but also deciding which plans will be certified as qualified health plans. Under federal law, if a state chooses not to establish and operate its own exchange, the federal government must step in and run the exchange on behalf of the state. Tennessee's exchange has been run by the federal government, as you all know, since 2013. When we came to CMS in 2017, we saw what years of really federal-centric command and control type policymaking had done to the insurance markets around the country. Like many other states, Tennessee's market was in a crisis. While premiums in the individual market nearly doubled nationwide from the year the Affordable Care Act's main rules went into effect in 2013 up until 2017 when we came in, Tennessee's situation was even worse. Premiums in the state's individual market spiked by about 150% from 2015 to 2019, and enrollment plummeted as a result. Unsubsidized enrollment, meaning enrollment among people who did not qualify for the ACA's premium tax credits, decreased by more than half in just 1 year from 2016 to 2017. Looking at the 2-year period from 2016 to 2018, Tennessee's unsubsidized enrollment nearly went away entirely, dropping by an eye-popping 76% in 2 years. And as many of you on the committee probably remember vividly, we were also seeing health insurance companies flee the market at that point, including here in Tennessee. We scrambled to work with former Commissioner McPeak and others in the state to make sure that there was even one health insurance company that's just one choice for consumers available in every Tennessee county. The market clearly was not working for those who needed it.
But starting at that time in 2017, we began to take a really different approach in addressing this crisis. First and foremost, we put in place policies that empowered states. We gave states the ability to have significant input and direction over key regulations, such as rate review, medical loss ratio, and risk adjustment. Finally, we greatly expanded what states could accomplish through the Section 1332 state innovation waivers, and we approved 15 reinsurance waivers around the country that in many cases reduced premiums by double digits and brought relief to these unsubsidized enrollees around the country. And as a result of these policies, in giving states more flexibility and really promoting competition and choice, average premiums for the benchmark plans in healthcare.gov actually went down for the first time in 2019, and they've decreased for 3 straight years. Competition on the exchanges has also increased as the percentage of counties with only one insurer offering coverage dropped from 52% in 2018 down to only 9% in 2021. In Tennessee, benchmark premiums have dropped by 6% in 2020 and again by 10% in 2021 as new competitions entered the market. But I believe as the political winds have shifted in Washington, there is a real danger that we're going to see a return to the concentration of regulatory power in the hands of federal regulators and taking away critical decision-making authority from states. In this environment, I believe that establishing a state-based exchange is one important way that Tennessee can preserve its ability to oversee its own market and plan for the future. So why should Tennessee establish a state-based exchange? There are 3 overarching reasons. First, establishing an exchange will give Tennessee more control over the direction of its health insurance market and will protect the state from restrictive and potentially harmful federal regulations. There's significant flexibility for states under the statute who run their own state-based exchanges. For example, you would be given full control over the qualified health plan certification process and in conducting outreach and marketing efforts. QHP certification encompasses all aspects of reviewing and approving rates, benefits, forms, marketing materials, and other materials under regulatory oversight. And in addition, states would have the authority to set and collect the user fee, as well as determine rules around special and open enrollment periods. And as you all know, we're in the middle of an open enrollment period right now for healthcare.gov that's going to last until August 15th. So we're already seeing, I think, Washington really going to something like year-round open enrollment, which in the long run will have detrimental impact on the market. Second, better technology and lower costs make it easier than ever for states to establish and operate their own exchanges, and you can save taxpayers and enrollees money. The cost of building an exchange has gone down significantly, while the technology and performance has improved dramatically. States that have already successfully migrated away from the federal platform to create their own exchanges have done so at a fraction of the cost. They're also able to run their own exchanges with a lower user fee than both states and the federal government. It's important to note today that enrollees on the federal platform, including Tennessee, pay user fees to the federal government in the form of higher health insurance premiums. In 2019, Tennessee enrollees sent nearly $50 million in hidden taxes to Washington to cover the cost of the federal exchange. The burden of paying the user fee falls primarily on taxpayers and unsubsidized enrollees who don't even directly benefit from the exchange. By establishing its own exchange, Tennessee would have the opportunity to reduce this burden on its enrollees and can charge a lower fee or can seek an alternative means to fund exchange operations. And finally, a well-designed state-based exchange can serve as the foundation for future market-based reforms. Because of the additional flexibility and regulatory design flexibility given states, exchanges can also be an effective platform for implementing market-oriented health reforms. In November 2019, CMS issued 4 waiver concepts that were designed to take full advantage of the ACA's Section 1332 state innovation waiver flexibility. And building the state's own platform can really help to make it a lot easier when the time comes to implement these reforms for your citizens.
Thank you. If you want to give a summary sentence or two, basically it's about establishing as Tennessee our own insurance exchange for healthcare, and that would give us some control over our local markets and avoid increasing intervention from the federal government. Am I summarizing it?
That's exactly right.
Fairly
yes.
enough. All right. Well, thank you for coming. Gentlemen, do we have any questions for Mr. Tate? Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman. Are you by chance, does your company by chance perform the services of helping states to set up something like this?
Unfortunately, there's just one person in the company right now, and that's me. But you know, I will say, you know, I do have a lot of experience in helping states set their exchanges up. We work very closely with Pennsylvania, New Jersey, and Nevada, the states I just mentioned. But you know, it's just me for now.
And how long have, who is your longest, which state has done this the longest? And can you give me some examples of any kind of innovations that may have come about in their time doing this?
Well, so it's really two different states. The state that has done it the longest is Nevada, and they migrated off the federal exchange about 3 years ago, and they've been operating at a lower user fee than the federal government has. The most innovative state is Georgia. They're the one that we actually use a 1332 state innovation waiver for them to basically waive healthcare.gov. So healthcare.gov in 2 years will no longer operate in the state, and instead you will have private health insurers and web brokers serve as really the shopping experience for consumers. So they would be the most innovative.
Thank you for that.
Stafford. Members, any other questions? Chairman Smith, you're recognized.
Could you clarify, is this going to be an expansion of TennCare?
No, not at all.
And those, the benefits, would this have to meet the minimum benefit plan of the ACA, or would this be innovations that the state could put in place in a private sector method? Thank you, Mr. Chairman.
Thank you for the question. So initially, what I'm talking about is just establishing a state-based exchange. You know, minimum essential coverage is a requirement that applies across the individual market and the group market today. You would not be waiving that requirement. However, in the future, if the state wanted to use a 1332 waiver to make more affordable products available in the market, building a state-based exchange could help to enable that in the future.
Thank you. Thank you. Thank you, Mr. Pate, for coming. We appreciate you, and I guess you will touch base with Chairman Terry, but we should be able to understand and take up his bill. Once again, thanks a lot.
Thank you.
All right. Gentlemen, we'll go back into session, and it will be wise to take the last item on our bill, item 14, House Bill 360 by Chairman Hawk. Chairman Hawk, you're recognized. Do we have a motion and a second? We have a motion and a second.
Thank you, Mr. Chairman, members. And we do have an amendment, drafting code is 4425, that will make the bill.
We have a motion on the amendment. Do we have a second? All those, without objection, we are voting on attaching amendment 4425 to House Bill 360. All those in favor, please say aye.
Aye.
Opposed? The amendment goes on the bill. Chairman Hawk, you recognize on the amended House Bill 360.
Thank you so much, Mr. Chairman, and forgive my having to step out, and I appreciate you taking the gavel. House Bill 360, as amended by the amendment, seeks to give our Tennessee Department of Commerce and Insurance a broad perspective on how insurance plans are doing when it comes to covering mental health care, especially in regard to the comparison of insurance coverages for physical health care. This bill will direct Tennessee Department of Commerce and Insurance to use existing resources to access federal reports from insurance plans to make this data available to us in a report that they will provide to the General Assembly. With that explanation of the amendment, I would request your support of the legislation, Mr. Chairman and members.
Members, do we have any questions for Chairman Hawk? Seeing none, are we ready to vote? Without objection, we are voting on House Bill 360. All those in favor, please say aye.
Aye.
Opposed? The bill goes on to full committee. Thank you, Chairman Hawk.
Thank you, Chairman and members.
And members, without objection, we stand adjourned. Thank you. This calendar are rolled to next week. Thank you.